Welcome to NEJM in Studio, your destination for discussions with experts about thought-provoking issues in medicine and health. My name is Dr. Harleen Marwa, NEJM Editorial Fellow. As we discussed previously, including race as a variable in clinical algorithms continues to be a widely questioned practice. One commonly used tool that has employed this practice is the pulmonary function test, or the PFT. Dr. Khazanchi, our guest today, is the author of the Medicine and Society article, Reform and Remedy for Imprecision and Inequity, Ending the Race-Based Evaluation of Occupational Pulmonary Impairment. He explained that, quote, race-based PFT guidelines were taught to clinicians for decades, even as questions arose about their validity and implications. Even though a consensus statement from the American Thoracic Society with an endorsement from the European Respiratory Society have recommended shifting to the race-free Global Lung Function Initiative PFT equation, gaps persist in implementation. Dr. Khazanchi is a resident physician in the Harvard MedPeds residency program and a health services researcher at the FXB Center for Health and Human Rights at Harvard University. His research examines policy-relevant questions at the nexus of health and carceral systems, racism in medicine, inequities in access to care, and more. His research on race in clinical algorithms has been referenced in federal regulations and has influenced state legislation. So today we sit down with Dr. Khazanchi to understand the historical, clinical, and regulatory contexts that have led to the imprecise and inequitable evaluations of occupational pulmonary function impairment and the health and economic consequences of those evaluations and strategies for remedy. So thank you so much for being here.
Great. Thanks for having me.
So with your deep expertise in the use of race in clinical algorithms, can you talk a little bit about what led you and your co-authors to look at PFTs in particular?
Great question to start us off. I think pulmonary function testing is a unique diagnostic algorithm. There are many algorithms across the human body that are using race as a proxy for biological characteristics or are being, used to inform clinical decision making. But pulmonary function testing specifically has implications financially, and that's in the case of job eligibility criteria, in the case of workers' compensation payments and disability payments. And I think some of those financial implications being directly related to specific PFT values is part of the reason why we wanted to conduct this sort of deeper dive. What we know is that, the adverse consequences of imprecision and inequity of PFTs in these contexts may be especially important because redressing those consequences might be a form of economic justice and reparation for populations that have been affected.
Absolutely. I think in medical school, we learn about how critical PFTs are to understanding pulmonary function and pulmonary impairment. But I think it's once you actually start seeing patients, you start to recognize some of these broader consequences that these evaluations have. Could you start by telling us how we got to where we are today and walking us through this history of the pulmonary impairment evaluation?
Yeah. So I think zooming out even further for a moment, the history of pulmonary function testing and spirometry as sort of part of the vestiges of medical racism is probably where this conversation begins. And it actually goes as far back as like the 1700s. So, Thomas Jefferson wrote these notes on the state of Virginia that were published in 1787. And even in these notes, he discussed, quote unquote, a difference in the structure of the pulmonary apparatus of slaves and sort of used this difference that he ascribed to biology as justification for the enslavement of African descendants. Similarly, in the 1860s, Samuel Cartwright, who is a slaveholder and a plantation physician, actually used research that he was conducting on slaves using spirometry in an article titled Cotton is King and Pro-Slavery Arguments. So again, using biological measures based in biomedicine to justify slavery. And he wrote that the expansibility of the lungs is considerably less in the black than the white race of similar size, age, and habit. A white boy expelled from his lungs a larger volume of air than a Negro half a head taller and 3 inches larger around the chest. The deficiency in the Negro may be safely estimated at 20%, according to a number of observations I have made at different times.
Wow.
So, you hear stories like this, vestiges of the distant past, yes, but it almost sounds kind of similar to using a race adjustment in pulmonary function testing today. And I think it's important that we recognize this history. I want to, especially for listeners who are unfamiliar with this type of story, direct them to Professor Lundy Braun's work, the late Professor Lundy Braun, who unfortunately passed away last year. But she wrote a book called Breathing Race to the Machine, The Surprising Career of the Spirometer from Plantation to Genetics. And this really sort of walks through this distant history all the way up to the present day.
Thank you so much for sharing that. I think it's striking to see how far back this really goes, and then to understand kind of its deep roots in this history of slavery and structural racism that's contributing to these linkages being made. I'm curious how some medical kind of belief and notion that was created in the 1700s has persisted to today, and what happened between then and now that led to this conversation that we're having and the things you wrote about in your paper.
Yeah, so our paper focuses on two things. We focus on this question of imprecision and this question of inequity. And I think the precision question in occupational pulmonary impairment is, again, where the story begins here. In the 1950s, the U.S. Social Security Administration had this massive task that they were assigned, which was trying to figure out people's capacity to continue working as a means of determining their disability payments. And doing this on scale was a really, really huge undertaking. So they were looking for basically clinical tools, devices, strategies that they could use to get proxy measures at things that might be important for somebody's capacity to work. So what they were trying to assess was, say, somebody's maximum oxygen consumption during exercise, or VO2 max. They ended up using resting spirometry measurements, in particular the forced expiratory volume in 1 second, or FEV1, right, which is still something we use in our spirometric equations today. They used that as their proxy measure, sort of trying to do analyses that showed that that was linked to that maximum oxygen consumption during exercise, and therefore it might be pertinent for somebody's capacity to work. So the problem with this, from a precision standpoint, was that the Social Security Administration drew these links and started using standard tables of FEV1 values as a means to determine total disability. But those links were a little bit blurry. In some cases, some studies found up to fourfold differences between FEV1 estimated and measured VO2 max values. So the proxy measure was there. They were trying to use it in a way that was precise and for a specific cutoff-based disability payment, but maybe it wasn't precise enough. And there was some overlap between people who met disability criteria and people who didn't, in a way that didn't really correlate with their actual VO2 max.
Right. And its deep connection with medicine and the practices and all the terms that we're very familiar with today. I'm curious if you could share a little bit about how this might have been challenged over the years, especially with consequences both on people's health outcomes, the kind of healthcare delivery they're receiving, but also on kind of these economic outcomes. One of the cases that really resonated with me in the article was the 1990s, when a judge actually said that this wasn't correct and went against kind of what the standard norm was.
Yeah. So in the 90s, there was this famous case at an asbestos manufacturing plant called Owens Corning in Baltimore. And essentially, there was a class action lawsuit because as evidence emerged, more and more people that worked at this plant had developed lung disease and were seeking workers' compensation for that lung disease. Now, what some of the Black workers at this asbestos plant in Baltimore realized was that they were receiving different payments than their white colleagues, despite having similar levels of measured lung function impairment. And that's because there were a reference equation being used to adjust their lung function based on their race. Now, the Black workers contended that this was discriminatory, but initially, when the circuit court judge that heard this case sort of heard arguments from all sides, he actually sided with the medical professionals, the American Medical Association, the American Thoracic Society, and various physicians who testified that basically this was the standard of care to use a race adjustment for the measurement of these workers' lung function. Now, he actually reversed his case later on. So this is the first example that we have that I know of a judge really standing up and saying, well, let me take a step back for a minute. Maybe this doesn't make a ton of sense, and maybe there is actually a valid counter-argument here being made by some physicians, by sociologists, by historians who are pointing to the fact that there were these vestiges of structural racism we're talking about, and that these effects were potentially inequitable and not grounded in sufficient evidence to justify paying somebody less for the same degree of lung function impairment. So it's a really interesting case, and it affected thousands of workers in the Baltimore area, right, who were seeking workers' compensation at this plant at the time.
Yeah. One of the things that really stood out to me about that case in particular was this, as you mentioned, this judge went against what leading medical organizations were saying, like the AMA and the American Thoracic Society. And so taking a step back as an individual clinician who is navigating evolving science and also navigating, trying to treat each patient for their specific presentation of an illness, how can individual clinicians kind of reconcile the science that they've been taught to critically interpret with the recommendations they're receiving from organized medicine bodies that they're supposed to be able to trust?
Yeah, it's really tough. I mean, the speed of scientific evidence generation and the speed of things getting to clinical practice are highly variable. Even when we find new evidence and begin to release new recommendations, it just takes time for things to make it out into day-to-day clinical practice. But I think for individual clinicians, in the case of the use of race in clinical algorithms, the recommendation I always have is just ask why. Why is race in this equation, right? Is it because it's to address some sort of an inequitable outcome and actually the use of race is narrowing an inequity? In which case, maybe it makes sense, right? That race is included in those algorithms. Or is it used to proxy for a biological trait like differences in lung function that in some of these old studies in the 1970s were ascribed to biological differences in chest size between Black and non-Black individuals, right? These arguments that, again, weren't really grounded in population-based reality necessarily, but were the arguments made to justify the inclusion of race as a proxy for biological traits that, to me, in today's present context, when we know that there are disparities in multiple things that affect lung function, including tobacco smoke, including environmental exposures, that disproportionately affect specific communities and may, at least in part, explain differences in lung function values by race. I think if you as an individual clinician take a step back, sort of ask that why question and realize there's a couple things that aren't quite adding up, that might be a reason to think twice about why race is in that equation.
Yeah, I think that that's a wonderful recommendation. Anytime you see someone using race or employing it in this way in a clinical algorithm, really questioning what was the origin of that and the purpose and where did the data come from. So from an organizational standpoint then, these leading medical organizations like the AMA, how have they responded to this? Because certainly those organizations are also full of clinicians who may also be asking questions like why, but it just takes time, as you mentioned, to kind of get through to those recommendations. So
Yeah. No, it's a great question. And I do think this has been a really dynamic space in the last few years with multiple medical societies really taking a step back and reevaluating race-based equations that they had previously recommended. In the case of pulmonary function testing, actually two of my co-authors, Nirav Bhakta and Sanja Stanojevic, were both members of the ATS task force that worked with the European Respiratory Society and really put together these recommendations after a long and very thoughtful process, engaging with historians like Professor Braun, engaging with patients, engaging with clinicians across the country and researchers who are experts in respiratory physiology to come up with clinical guidelines for which reference equations to use that are grounded in our most current evidence. And as you mentioned sort of in the introduction to today's talk, that guideline ended up recommending the use of the GLI global race-neutral equations, which is sort of a departure from the past when ATS had recommended the use of race-specific reference equations. So they came to that decision not lightly, right, after a very thorough review of the evidence. And I think seeing the ATS put that stance forward is extremely encouraging for where the future of the field goes.
Yeah.
Now, with that said, what our piece talks about is specifically occupational impairment, which is a little tricky because in many cases, occupational impairment evaluations are not governed by, say, a national medical society. They're governed by state-specific regulations or federal employee regulations or Veterans Affairs regulations that sort of dictate how those workers' compensation impairment evaluations are conducted. And the problem with this specific topic is that it's heterogeneous, right? States have the ability to determine how they want to recommend that clinicians evaluate occupational impairment. And typically in 38 states across the US and the US Federal Employment Compensation Program, actually even in several countries around the world, states and these other stakeholders are recommending use of the American Medical Association's Guides to the Evaluation of Permanent Impairment, which have been published since the 1960s, revised almost every decade, and try to keep up to date with the most current science. I say unfortunately because this Guides to the Evaluation of Permanent Impairment, until, a proposal that we recently submitted was still recommending the use of race-based pulmonary function testing, among other things that feel a little bit outdated to us at this point. And even in some states that haven't updated those statutes, they're recommending the use of AMA guides documents that were published in the 1980s and the 1970s that are outdated. So some states haven't actually kept up with changes to the AMA guides themselves. So this heterogeneity is one of the problems that we really point to as an opportunity for advocacy and for institutional change, which is even if the AMA takes our proposal and says, we're going to go ahead and, change the equations we're recommending in the guides, that doesn't reach clinical practice until state statutes, federal statutes, are changed to actually reflect the updated algorithms or updated versions of the AMA guides, if that's what they're recommending to use.
Right. Well, thanks to you and your co-authors for your leadership in this space and for really being able to advocate for those necessary changes. Could you talk a little bit more about what some of those proposed changes are for that next edition of the AMA guide? And then based on your experiences kind of moving this topic forward, what would you recommend to physicians who might be practicing in places where there are being kind of outdated recommendations used by state legislators?
Yeah, so great question again. I think, the updates that we recommended to the AMA guides were really seeking alignment with the American Thoracic Society standards, which we believe are sort of the most appropriate and up-to-date national consensus guidelines at this point. So there were a couple of things that we noticed in the pulmonary chapter. The first was, of course, this obvious point about reference equations that needed to be updated. Pulmonary chapter was still recommending sort of the older NHANES equations, but now with the shift to the GLI equations, that's what we advocated for as well. We also just noticed some, again, vestiges of past conversations in the occupational impairment space. Occupational impairment evaluations have really moved farther and farther away from subjective beliefs about patients' symptoms that they're reporting and sort of qualitative experiences, and more towards quote-unquote objectivity. And I would put objectivity in quotes if I was writing about this because, as we've talked about a little bit, the evidence for the true objectivity and precision of spirometric cutoffs to determine how impaired somebody is functionally in their life, in their ability to work, it's a little bit muddy. So I think one thing that we also recommend is sort of removing language that blames patients or says patients might be reporting a symptom that you shouldn't believe, right? There was sort of language that made insinuations that we felt were maybe beyond the scope of what a clinician should be trying to ascertain. We should take what our patients are telling us at face value when it comes to functional impairment and also use our objective tests to try and ascertain what's actually going on here. So I think part of our recommendation is sort of language related. And the third piece I'll just mention is we include some stipulations about pulse oximetry, which is an objective data point that can be used to measure the degree of somebody's oxygenation being impaired, but at the end of the day is also affected by, race and skin color in particular, because we know from studies published in the New England Journal and elsewhere that patients with more pigmented, darker pigmented skin may have false pulse ox readings that are reading lower than they actually are or higher than they actually are in reality. So this point about pulse oximetry is important for occupational impairment because that may be one of those objective data pieces that sort of contributes to somebody's overall measured disability.
Yeah, it sounds like a move, as is being done in a lot of parts of medicine, to make things more patient-centered, really think about the patient experience broadly and treat them holistically. It's really interesting to look at something like pulmonary impairment that has so many different pieces that make it up, whether it's, asking patients about their activities of daily living, using, metrics like PFTs or using tools like pulse oximetry that can be problematic for the reasons you mentioned. We've talked a bit about how medical organizations are responding to this, things we can do at kind of the state and local level, but can you talk a bit more about how federal influence is impacting this, specifically as it pertains to 1557?
Yeah, so there's been a lot of federal movement in this space in the last 6 to 12 months in particular. It dates back a little bit before that. So the House Ways and Means Committee a few years ago issued a request for information to medical societies that were at the time using race-based clinical algorithms or recommending them to clinicians in practice. And I think this really set off sort of a stream of federal activity with the U.S. Food and Drug Administration issuing guidelines on discrimination and clinical algorithms that were sort of regulated as medical devices. The Office of the National Coordinator for Health IT within HHS also issued sort of their own guidance for algorithm developers. But perhaps most notably for clinicians and hospital administrators, the Affordable Care Act has a section called Section 1557, which is focused on discrimination in healthcare. And this is really massive portion of the ACA that was so important. It was protecting patients from discrimination on the basis of protected classes. And in 2024, the Biden administration formalized a final rule on this Section 1557, which focused on specifically clinical algorithms. So a portion of this rule, actually for the first time in federal law at the HHS level, said that health systems have an obligation to mitigate or at least investigate discriminatory tools that are used in clinical practice. Now, the reason this is important is because HHS has enforcement mechanisms around Section 1557. So it doesn't come without teeth. It just depends on what HHS decides to do. But May 1st of 2025 was sort of the date when this obligation for health systems to identify and mitigate any discriminatory clinical algorithms that they're using rolled into effect. We don't know how the current administration is going to interpret this, but it's really, really important because health systems in theory have an obligation to get up to date on standards of care across the country.
Absolutely. And important for physicians to know that this is happening so they can also ask their health systems or, take on leadership roles within their systems as well. And ultimately, this is all going towards that goal of patient-centered care.
Yeah, a covered entity under Section 1557 includes an individual practitioner, a health system, really anybody who's receiving federal dollars, even if it's in the form of like health insurance payments. So essentially, it implicates all of us, right? It says that the ecosystem of healthcare delivery has an obligation to, again, identify and mitigate the use of any discriminatory algorithms in clinical practice. And so when there's evidence for an algorithm that's causing harm, as I believe is the case for pulmonary function testing at this point, the obligation to move towards a race-neutral alternative is necessary. And seeing how HHS enforces this will be really interesting in years to come.
Yeah. Bringing it back to that patient-centered focus, I'm curious if you can also share a bit about the health consequences of having some of these tools be potentially flawed in these ways.
Yeah, as we've mentioned, the economic consequences are profound. It's job eligibility, it's workers' compensation. There was a paper published in the New England Journal back in 2024 that I was a co-author on, led by James Zhao. And this study, called Implications of Race Adjustment and Lung Function Equations, estimated on the order of millions, if not billions of dollars in reclassified workers' compensation payments if everybody, say, were to be able to go and seek, reevaluation for impairment. So economic consequences, certainly profound. I think as data has emerged on race-neutral equations as well, we've seen a growing sort of emphasis that these equations may actually be better at predicting clinically significant endpoints. So some of the evidence that the ATS cites in their guidelines and that we cite in our paper demonstrate that race-neutral PFT equations better predict a variety of these clinically meaningful endpoints like respiratory symptoms, like hospitalization. And so I think that that's a really important part of this story too, right? Which is this is not just a decision that we made on the moral argument alone. This is also a decision that we're making based on clinical evidence that these equations are just as good, if not better, than the race-based equations we were using previously.
Yeah, definitely. I think it's so important to bring it back to both these economic consequences, which certainly have upstream consequences on folks' health, but really like what's happening in the clinical setting as well. With some of these changes and recommendations, I mean, I think we know this from clinical practice, there can be changes made to guidelines and recommendations, but it takes a while to actually trickle down into the hospital setting or the clinic setting. And so can you talk about how that process has been going, if there's implementation gaps, and maybe some things physicians can do to help close those implementation gaps?
Yeah. I mean, at the individual level, I think the first question physicians should just ask is, what are we using at my health system, right? I think asking that question can open the door to a lot of conversations with PFT labs. We knew, and I think the ATS knew when they made this recommendation, that there would be implementation gaps because, as Professor Brown writes about in her book, as we talk about when we're discussing this work, in some cases, the equations are built into the machines. They're not a correction that's made after the values are output by the machine, but sometimes the equations are actually programmed into PFT machines. And so when the values are reported out, they've already maybe been adjusted for a patient's race. So the process of undoing the use of these equations can be complicated at the institutional level. And I think that's why really hitting this on all fronts, right? Addressing it from the ATS side, addressing it from federal stakeholders, right? Like NIOSH, like OSHA, like the VA, federal stakeholders that have an influence on what clinical practices are doing in different settings. And then lastly, addressing this in the occupational impairment space, the workers' compensation space, by updating the AMA guides, by updating state level statutes that determine what clinicians are using to evaluate patients' pulmonary impairment. I think all of these steps help change the ecosystem around pulmonary function testing, right? It's not just one lever. We know that clinicians are practicing in many environments, evaluating patients in many contexts. And so demonstrating the reasons why these equations are better, first of all, with further clinical research. And second of all, demonstrating how to implement this depending on what your health system is doing. All of this is sort of the work in the next few years ahead.
Well, thank you so much for your leadership in this space and for putting together the history of this story and how it's led to where we are today. I think it's unfortunately unsurprising that something that has a history that dates all the way back to the 1700s is this deeply integrated into the system. And so thinking about all of the different nuance around how to pull it out of the system and build a better system for our patients is so important. I'm curious, I know that your research, this paper was specific to pulmonary function impairment, but you look at this issue more broadly as well. What lessons can folks learn from the story here that can be applied to other tools and medicine more broadly?
Yeah, it's a great question. I think the story of pulmonary function testing is such an interesting one for me personally, because I think this story in particular led me to recognize in a much deeper way the importance of the history of medicine and the sort of vestiges that led us to where we are today, as we've discussed multiple times, right? Hearing that story of this, slave-owning plantation physician who wrote about essentially racial differences and race adjustments and spirometry in the 1800s, and then reading a paper today that says this is clinical practice. I mean, I think that is jarring, and it's something that makes me question, how we got to where we are today in a deeper way. So for me, when I was a medical student that was first learning about this, I think that's what motivated my interest in these issues. That's what motivated many of our interests in these issues, is we just felt like the connections were so clear when we took a look at that history, but it wasn't until we took a look at that history that we realized it. So for me, I think that's one big takeaway. I think the second is, changing an equation isn't the solution. The solution is repairing things for our patients, right? So I'm happy that the national guidelines are different, but most of our piece doesn't focus on that. We just say, we know the national guidelines are different, and here are the 30 other things that we have to do to actually help this reach the people who need it. And I think I'll emphasize one specific point on that, which is we really feel strongly that there's a need for remedy. And what I mean by that is a recognition that patients have been harmed by these tools and will continue to be harmed until they're sort of shifted out of clinical practice. And as a result of that, we need to offer a pathway for repair, for a remedy for those harms. And the kidney folks have done this the best, right? Because right now on a national level, the Organ Procurement and Transplantation Network, which is the national sort of transplantation organization governed at the federal level, it sort of introduced a proposal to allow wait time modifications where kidney candidates who are affected by the race-based eGFR equations were able to actually have their transplant centers submit old GFR values that would have crossed the threshold of 20, which merits transplant listing, and allow them to get the time that they would have had on the wait list from that older value up until the present back added to their transplantation waitlisting time. So that's direct redress. That's a race-specific harm that was redressed in a race-specific way. And I think something like that would be appropriate for workers' compensation, right? Maybe it's saying that patients have a 3-year window to get re-rated. If they had a rating in the last 3 years and were receiving payments, maybe it's making up the difference in payments if their rating is lower than it would have been had it been with a race-free equation. And so I think thinking about those opportunities to actually remedy harms that have happened is just as important as thinking about the forward-looking, what are we going to do next? How are we going to fix this from an implementation standpoint? And that's definitely something that stood out as I've worked on this.
Yeah, I think it's so important. And to kind of go back to something you said earlier, you had recommended that one thing physicians can do is ask the question, why? And it's something that we're taught so much in our training in medicine. Always ask why. Why is the patient having these symptoms? Why is the medicine or the treatment we're giving them having a different result than we expected? So we're taught to ask why all the time. So it's really reframing that curiosity and that critical thinking back at us and back at ourselves to make sure that the systems that we're practicing in, the systems that we're promoting for our patients are there to promote their health. And so I really appreciate all the different perspectives you've given us, as well as kind of the tangible steps that folks can take. To close our conversation today, one of the things that we always, like to ask our guests is, what is one thing about your research that you wish other people would ask you more often?
It's a good question. I'm trying to think what we haven't covered already because we've gone
I
through so much of
know.
it. I think the biggest thing that I enjoy thinking and talking about the most is just trying to come up with what a different future looks like, right? What is the counterfactual to where we are today?
Mhm.
And for me, that's where work that quantifies the negative impacts of these equations and really looks towards this remedy and redress is the most important, right? Because I think it's actually a quantifiable question to say how many people that had a racial group that would have been disadvantaged by pulmonary function testing equations of the past actually received a lower disability compensation than they should have. I mean, I think that's a question that individual clinicians, that medical societies, that regulators, that insurance agencies that are paying out these, workers' compensation payments could all take on together. And so that's really where my focus is now. And that's where I want us to be thinking as a community is what can we do to basically move towards a national standard of clinical practice, of course, but
Mhm.
also take a look back and what can we do to help the patients that may have been affected by this previously.
Absolutely.
Yeah.
I mean, that's why we're all here and grounded in this career in medicine is to help our patients and be solution oriented. So I want to thank you again for your time, your insight, your expertise today, and for joining us on NEJM in studio. I think in understanding where we have been, it helps us understand where we should go next. And so thank you again to our guest, Dr. Khazanchi. The full article that we've discussed today will be available on nejm.org. Funding for this interview is provided by the Doris Duke Foundation, committed to building a creative, equitable, and sustainable future.